Good morning, good afternoon, and good evening. I'm John Klein, MPH graduate from 1984 and professor of pediatrics and associate vice chancellor for research at the University of Illinois at Chicago, and a member of the planning committee for this year's Alumni Week activities. And it is my privilege to introduce one of our lightning talks for today's session, centering Black adolescent voices in health equity research. Our presenter is Bianca Allison, who is a primary care pediatrician and a health services researcher at the University of North Carolina at Chapel Hill. Dr. Allison received her MPH in health and social behavior from the Harvard Chan School of Public Health in 2016, and she's currently an assistant professor in the Department of Pediatrics in the Division of General Pediatrics and Adolescent Medicine at UNC. And so I'm delighted to turn this over to Bianca, and then we'll come back for some question and answer at the end. Take it away.
Well, thanks so much for that introduction, John. So again, I'm Bianca Allison, and I'm really excited to share my work with you today. I'm really passionate about particularly providing patient-centered and equity-focused primary care for adolescents. And my clinical and research work really focuses on sexual and reproductive health promotion in North Carolina. So to build my case for why we need to do better to center Black adolescent voices in research, I'd like to first provide primers on North Carolina, as well as a brief history of racial health disparities in the US, so that we are all on the same page with why reproductive justice is important. Then I'll explain why I specifically focus on adolescent reproductive justice and explain what barriers they face in accessing sexual and reproductive health care. This background will lead me to discuss the secondary data analysis research project that I did last year that really changed my views on how I should be conducting sexual and reproductive health research with and for Black adolescents. I'll end by talking about how I plan to do my research moving forward in a way that centers health equity by focusing on the voices and experiences of Black adolescents. So to start, let's talk about North Carolina. So North Carolina is in the mid-Atlantic region of the United States and mostly contains counties that are considered rural. Additionally, it's quite diverse, with almost 40% identifying as non-white. It has a larger proportion of Black residents than the US average. And you can see here that there are significant inequities in social determinants that exist in North Carolina that are worse than national averages. And this includes lower median household income, lower life expectancy, higher numbers of uninsured individuals, higher maternal mortality, and many residents that are living in primary care shortage areas. So now let's talk briefly about the history of racial health disparities that exist in the US. So slavery and then Jim Crow laws created two different and disparate healthcare systems, one that centered whiteness and white supremacy that included transparency and increased health literacy, and the other that centered Blackness and othering and included experimental treatments and promoted a lack of respect for bodily autonomy. This was especially true in the realm of women's health. Enslaved women and those living in the Jim Crow era South after slavery faced, often without consent, forced sterilization, hysterectomies, and natural course research on sexually transmitted infections. While often less blatant than these historical examples, there is a legacy of reproductive coercion and implicit bias in the healthcare system that has continued until today and transcends Black populations. These biases can affect the care received by women in prison, women of lower socioeconomic status, sexual and gender minorities, women who identify as Native American, Latinx, and other people of color. And unsurprisingly, the literature shows that many individuals who identify with these groups have also expressed a mistrust in the healthcare system. So given this historical context and the current realities experienced by women and gender nonconforming individuals, the reproductive justice movement gathered steam in the 1990s. The definition of reproductive justice is the human right to maintain personal bodily autonomy, have children, not have children, and parent the children that we have in safe, sustainable communities. The term reproductive justice was coined by Sister Song, which is the central organization in the reproductive justice movement. They do significant education around these topics and partner with many nationally known organizations that are working in reproductive rights, such as Planned Parenthood. They advocate that reproductive health goes beyond individuals and their choices and is directly affected by other factors such as race, religion, or sexual orientation, financial immigration or disability status, and environmental and political conditions. And this is a socioecologic framework that I want us to think more about as we move into discussing how to promote reproductive justice through research. So with that context in place, I'd like to switch gears a little bit and discuss why I focus my reproductive justice work on adolescence. So adolescence is marked by both a chronological age and developmental stage that's specifically dedicated to the processes of transitioning from child to adult. Almost 10 years ago, Blum et al. Developed a set of 5 goals for healthy adolescent development, which include engagement with learning, emotional safety, development of self-efficacy, and the acquisition of decision-making skills, in addition to physical and mental health. You can see through this socioecologic framework that there are a number of factors that intersect to support this development, which sounds very similar to what we just discussed with reproductive justice. And I would argue that similarly to the way schools can nurture this growth, fostering independent and autonomous engagement with the healthcare system can also facilitate this approach to adolescent development. Additionally, the legal system protects adolescents' independent pursuit of some healthcare without parental consent through minor consent laws across the United States. These include sensitive services like pregnancy testing, prenatal care and pregnancy services, birth control information and contraceptives, testing and treatment for sexually transmitted infections, substance abuse treatment, and in many states, outpatient counseling and mental health services. However, there are a lot of barriers that plague the medical system and impact adolescents' pursuit of these services. First, this can include little time alone with their provider, an aspect of healthcare that's often initiated by providers, and few providers who might be comfortable initiating and following through on conversations about sensitive topics like sexual and reproductive health. Second, there may be poor referral networks for pursuing these services if they're not available in that clinic. Third, there are barriers to confidentiality, given that private insurance will often transparently share with parents the services that adolescents have received through insurance. And finally, even when all of these pieces are in place, provider bias and personal beliefs around sexual and reproductive health can disproportionately impact the kinds of counseling and care that many adolescents receive, especially those who identify as Black, Indigenous, people of color, sexual and gender minorities, or have lower SES status. One systematic way that bias has been taught to providers is actually through this encouragement of tiered effectiveness counseling for contraception, which has been recommended by many national organizations as the best approach to contraceptive counseling for adolescents. It focuses on emphasizing the most effective forms of contraception, like implants and IUDs, and de-emphasizing less effective forms of contraception, such as birth control pills, condoms alone, or the rhythm or pull-out methods. And these can bias providers towards thinking that effectiveness is the most important value in contraceptive decision-making, and that all adolescents should be on highly effective forms of birth control. It completely ignores any other values that adolescents may also prioritize, such as difficulty or ease of access, privacy in acquiring or continuing these methods, and painfulness or side effects of use. So this all sets up a conversation about my own research and how I've changed my tune from being a health disparity scholar to a health equity scholar by again considering a broader framework such as a socioecologic framework to my work. So my research to date has focused on mapping the landscape of disparities in contraception access and utilization. However, this project really stopped me in my tracks and made me reconsider how I was approaching research that would ultimately create an intervention. So we analyzed North Carolina Medicaid data from 2013 to 2018 to look at how contraception utilization and access has changed over time. So you can see here that I found Black adolescents in North Carolina, as well as rural adolescents in North Carolina, are more likely to use and maintain certain forms of contraception compared to their white and urban peers. However, when I went to write this study up, I struggled to interpret this data. Are Black and rural adolescents more interested in contraception? Are they feeling coerced by their providers or peers to get these types of contraception? Or do they lack access to removal services when the time comes if they've had an IUD or implant in place? I couldn't stop thinking about these questions. And so my research program has essentially shifted focus. Instead of just documenting disparities and using that information to try to improve services, I now strive to improve care delivery by focusing on reproductive justice and patient autonomy, which essentially takes a more thoughtful and nuanced approach to understanding the socioecologic model that determines contraceptive and reproductive health choices. I'm especially interested in developing interventions that center adolescents' developmental stage and self-knowledge to provide counseling that ultimately aligns with their values and goals. So how does one do this? It's intimidating and there's really no perfect answer, but at various stages of the research process, we can start to shift our focus from a disparities lens to an equity lens. So one important part of the research process is changing the topics that we're counseling, which to me means focusing on promotion of reproductive justice and patient autonomy instead of just pregnancy prevention. Another important part is how we create the specific questions that we're asking and framing them in a strengths-based or health equity-oriented way. So one way to do this is by finding an adaptive and patient-centered framework, such as the person-centered contraceptive care framework. This framework allows us to consider all the different aspects that impact an adolescent's decision-making around contraception, moving beyond what we can easily measure in big data and bringing in some more abstract concepts that are seen at the top of this slide, like racism, sexuality and gender discrimination, and stigma. It also forces us to consider all aspects of the continuum of care, including the quality of the care that's provided. For me, this helped frame the research question that guides my work now. How can we support adolescents in making decisions for their reproductive health that aligns with their own values? And finally, we may want to reconsider the research methods that we use, especially youth-engaged processes to center adolescent developmental stages and self-knowledge to design interventions that impact them. I'd like to make this last point about methods more concrete by discussing how I plan to leverage these tools for health equity-focused research through my next research projects. So I plan to take a community-based participatory research approach by prioritizing building collaborations with community partners. This will help me in designing the formative qualitative study that will underpin the intervention work that I want to do. These partners will also assist me with recruiting a diverse group of adolescents across North Carolina to join me. I also plan to recruit a diverse team of researchers, including research assistants who are Black and young adults, to do the face-to-face interactions with Black, young adult, and adolescent populations in my study. I plan to use qualitative data to guide future research, including understanding adolescent perspectives on how they obtain and mobilize sexual and reproductive health information, and to understand their experiences in primary care clinics with reproductive health counseling. In my survey work, I will use patient-centered outcomes to help focus on collecting data that is directly relevant to the experiences of patients. I plan to use validated tools that measure reproductive autonomy and patient satisfaction to guide my intervention evaluation efforts as well. And finally, I plan to use human-centered design, which seeks to engage the end users throughout the process of intervention development. I'll put together a design team of interested and diverse adolescents, as well as human design experts, who will meet to analyze the qualitative interviews and quantitative surveys, and then redesign or design anew a sexual and reproductive health counseling support tool that can be used by providers to counsel and engage adolescents in primary care in a way that aligns with their unique individual values and goals. So I hope that this talk has given you some food for thought about how to engage in health equity work, especially when you're thinking about engaging teenagers around sexual and reproductive health care. Though there's a fraught and long history of reproductive coercion in the US, and even though healthcare providers are often taught to harbor certain biases around adolescent reproductive autonomy, we can write a new narrative moving forward. Big data can help us uncover where the differences may lie, but our real responsibility is actually to meaningfully improve health equity, and if you're so inclined, to promote reproductive justice. This can include thinking about the systems and structures that influence contraceptive access and care, and using community-engaged and person-centered methods, such as CBPR, qualitative data collection, and human-centered design. Thank you.
Thank you so much. That was a wonderful talk. I think it's such an important area, and I have a couple of questions for you to think about it and answer for our audience today. First of all, I think in the approach that you're taking, there seems to be an underlying assumption that that knowledge leads to better individual decisions, and that applies when it comes to pregnancy intentions. And I'm curious how you balance that when you think about the systems of belief, which might not include deliberate planning around reproductive health outcomes, and how that then relates to persuasive techniques like guided decision-making, which can help create some of those informed decisions.
Yeah. That is a really good question and very complicated. I think that you're right, that knowledge alone is not always enough for especially adolescents when they're making these types of decisions, that there are a lot of competing kind of values and experiences that may change the way that they mobilize some of this knowledge. But you're specifically asking about teens and sort of the way we counsel them, or even providers and having knowledge
Well,
about.
I think, teens in particular, sort of when
Yeah.
teens say, oh, well, if I get pregnant, it's God's will, for example.
Mm-hmm. Right.
How do you put that in the context of reproductive justice?
Yeah. So, yeah, I think that there's, everyone has values that come from somewhere. And so I don't think that any of us are sort of just creating these values in a vacuum. I think they're often informed by, our own personal beliefs, whether they be religious or cultural or things that we've learned from our communities. And so I don't think that it's really our place to always necessarily determine if, these values are valid or are higher priority than other values. But we can always try to engage more meaningfully and maybe at probing why a teen might have certain beliefs, or be expressing certain views, so that we can better understand that, so we can provide the appropriate counseling, and ensure that they're not feeling coercion in other ways, in terms of where these values are even coming from. So I think that, a counseling support tool for providers that really helps them not just have these conversations and follow a specific script, but includes some probes when, teens are asking or responding, to questions about their values, I think is really important. So hopefully it would be a little bit nuanced. And so we can really ensure we're getting to the heart of why teens have their beliefs.
Great, thank you. So now to maybe take a question about the care system. A lot of times we talk about access being the capacity of a system, but the other way to think about access is good quality utilization of care. And I think you referenced that, as to whether clinicians actually provided the kind of care that's needed. I'm wondering what you would do to try to make the health system and our clinicians more accountable for delivering that quality. That's part of what young people need for reproductive rights and health.
Absolutely. Yeah. So I think this highlights the exact tension that I sort of experience with kind of using big data and getting a sense of where access is and isn't happening, across our state, but then not being able to kind of understand how that's working in terms of the quality of the care that's being provided. And so this is where I think even if folks are working in big data, that it's still really important to think about the people on the ground who are experiencing the care and trying to figure out what types of tools, whether that be validated surveys or qualitative work, that can help guide decisions around improving the care that we're providing. So it goes beyond just providing more access, having more providers who are trained to put in an IUD or an Explanon, but really making sure that we're actually providing high quality care. And so, again, to me, that means potentially following up with patients and getting their perspectives on the quality of care they're receiving, using these validated surveys that have patient-centered outcomes kind of at the heart of them. And not just relying on big data.
Great. And finally, I think a question at the policy level here. This last week in particular, I think we've seen with the new abortion restrictions in Texas, the latest in a series of conflict over what does reproductive rights really mean. And this ongoing debate about preventing abortions versus preventing pregnancy versus preventing sex. Mm-hmm. And so I'm curious how you put the policy debate around adolescent reproductive justice in the context of the historical disparities and the institutional racism in society, and what you see as opportunities to try to change that dialogue with the kind of data that you're working from.
Yeah, that's a really thoughtful question. I think the first thing, as with anything related to reproductive justice work or working in racial justice, is really just a lot of education that there exists this history of reproductive coercion, and that, you know, certain populations, both very explicitly and very implicitly, have gotten sort of different standards of care, different quality of care, that a lot of times those biases are driving a lot of the decisions providers might be making, or the way that they're counseling and providing care, and kind of bringing those things to light so that we can all move forward with a shared understanding of the history that we're living in, or the history that has sort of shaped the system that we live in now and are working in. And so I think hopefully just people having these types of conversations more explicitly is the biggest thing. Groups like Sister Song and other kind of advocates in reproductive justice have tried to do a lot of work around education. So I'd encourage anyone interested to sort of look at the resources available online. There's a lot of short courses around reproductive justice and sort of the history of reproductive coercion and things like that, that have, again, disproportionately affected certain populations. And then if they're in positions where they can advocate, you know, to policymakers, or, you know, have the ears of those folks, that obviously getting them to even engage in some of these conversations is really important, but really hard work, obviously. And so I think, yeah, once we have the knowledge of sort of the history, it becomes harder to ignore, I think. And even if that's just in your individual interactions with patients, and keeping those things in mind, or if you're in a position where you can advocate on a broader scale, I think it's harder to ignore once you open your eyes to it. So I'm hopeful that things can slowly change as we become more educated and willing to talk to each other about these topics.
Well, thank you so much, and thank you for sharing this perspective on adolescence and health equity as a component of public health through the life course as part of this year's Alumni Week activities. Dr. Bianca Allison, thank you on behalf of the Planning Committee. Thank you all for being with us, and I hope you'll join us for more of the lightning talks and for some of the other live sessions during this week. Thanks again.